We're going to go ahead and get started with our discussion today. My name is Dr. Rachel Vreeman. I'm a pediatrician and an HIV researcher, and I'm the chair of the Department of Global Health at the Icahn School of Medicine at Mount Sinai, where I direct the Arnhold Institute for Global Health. We have been hosting a webinar series now for a year that has been focused on COVID-19 and global health, and I'm really excited for today's discussion. We're going to be talking about women in leadership and what it looks like to achieve an equal future in a COVID-19 world. What makes me the most excited are the three incredible women who are joining us today from three different parts of the world. And I am really looking forward to hearing their stories, to asking them some questions. I could probably spend all day talking to them, but I'm going to restrain myself and keep us to our hour today. I wanted to let everyone know who's joining us that we are going to leave some space for questions at the end. So if you would like to put questions into the Q&A box, you're welcome to type them there and we'll see them at the end. I'll try to remember to remind us after we've had some discussion time. Without further ado, let me introduce the incredible three speakers that we have joining us today. So in no particular order, let me start with Dr. Indira Basnet. Dr. Basnet has more than 38 years of experience working in Nepal's health sector. She started her career as a medical officer in a public health facility. She worked as the country director for a highly well-established international NGO, and she served as an advisor for bilateral agencies working in the health sector in decision-making roles at the policy level for Nepal's Ministry of Health and Population. Dr. Basnet has also worked for many years with Nepal's Safer Motherhood Project and has a deep-rooted passion for reducing maternal mortality in Nepal. During her work with bilateral agencies and the international NGO, particularly in reproductive health, she's achieved a successful record of accomplishments, including Ministry of Health and Population approval for multiple policies to support mothers. Before she joined the Nepal Health Sector Support Program, she also worked with an international NGO called Possible for a year, engaging in operationalizing their model in two remote districts of Nepal, Dhulakal and Acham. She has been a strong advocate for reproductive health rights, and her major strengths include evidence-based advocacy for policy reform and translating reproductive health rights into practice. She's an author, a reviewer for the peer-reviewed Reproductive Health Matters journal, and she currently serves as the chair of Possible Nepal, a nonprofit organization focused on research and innovation rooted in equity and social justice. So welcome, Dr. Basnet. We also are delighted to welcome with us today Dr. Violet Naanyu, who's joining us from Kenya. Dr. Naanyu is an associate professor in the Department of Sociology, Psychology, and Anthropology in the School of Arts and Social Sciences at Moi University in Eldoret, Kenya. She serves as the co-field director of research for the Indiana University Moi University Kenya program, or AMPATH, and she's the founding director of AMPATH's Qualitative Research Core. She's also a member of the Africa Ethics Working Group and a member of the Kenya National Bioethics Committee and the National Commission for Science, Technology, and Innovation in Kenya. She's the co-chair for the Indigenous Populations Working Group for the Global Alliance of Chronic Diseases. Dr. Naanyu holds a master's degree in sociology from the Indiana University, a master's degree in medical anthropology from the University of Amsterdam in the Netherlands, and a PhD in sociology from Indiana University. As if those were not enough degrees, she's currently pursuing a master's in global bioethics as well. Her research explores the individual and social cultural factors around illness, health, and healthcare. She's particularly interested in implementation science, the evaluations that are designed to improve well-being in healthcare delivery in resource-limited settings. And she's especially passionate about research ethics, especially in the context of African countries. As she and I have partnered for a number of years, I can attest that not only does her work often engage in community participatory approaches, but she has extensive experience designing and implementing qualitative research projects. She is also married and the proud mother of 6 children. So welcome, Dr. Naanyu. We're delighted to have you joining us today as well. And then our third guest is Dr. Jasmin Moshirpur. Dr. Moshirpur is a professor of obstetrics and gynecology, and she is the dean for the Elmhurst and Queens programs at the Icahn School of Medicine at Mount Sinai and chief medical officer for the New York City Health and Hospitals, the Elmhurst and Queens Hospitals. Dr. Moshirpur received her medical degree from the Shiraz University School of Medicine in Iran, and she immigrated to the United States for her residency in obstetrics and gynecology at the Mount Sinai Medical Center. She has completed a fellowship in gynecologic endocrinology, and she's board certified in obstetrics and gynecology. As the director of the Obstetrics and Gynecology Outpatient Department at the Elmhurst Hospital Center, she pioneered an outstanding program for the community that rigorously emphasized preventive medicine, including routine pap smears for detecting early cervical cancers, as well as performing breast physical exams for adult females who were admitted to the hospital. This laid the foundation for her career with a passionate commitment to improving and redefining women's healthcare and medical education. She also helped to establish the Cancer Center of Excellence at the Queens Hospital Center, and she was appointed the director of the Department of Obstetrics and Gynecology in 1975 and held that position for 26 years. She has received many honors, including the Schnepp's Communications Healthcare Hero Award in 2020, the Glamour Woman of the Year Award in 2020, the Transitional Services for New York 2016 Physician of the Year Award, and many others, including the 2015 Jacobi Medallion. I'm not going to list all of your awards, Dr. Moshirpur, but they are many, and we are grateful for them and really do want to honor you in that. Dr. Moshirpur is also the president of the Queens Gynecological Society and the vice chairman of the board for the Iranian American Medical Association in the United States and a member of the American Academy of Medical Directors. She is also, like each of the women here, a true leader and an engaged citizen and physician. Dr. Moshirpur has 3 children and 10 grandchildren that she is also very proud of. Thank you so much to all of you for joining us today. You know, in March, we celebrate International Women's History Month. And of course, this month is drawing to a close. I cannot think of a more delightful way to draw this month to a close than being together here with it. So we're really delighted to have you join us for this webinar series. Our theme today is Women in Leadership and what it looks like as women in leadership, walking through global health, the current challenges of COVID, and where we are in moving forward population health as well. We're really excited to have each of you representing partnerships that the Department of Global Health at Mount Sinai has, partnerships in Kenya, partnerships in Nepal, and also partnerships in Queens, where we have been partnering with Elmhurst Hospital and Queens Hospital in the public health system as well. Now, of course, you know, we've been hearing, I think many of us, about the impacts of the COVID-19 pandemic, both direct and indirect, on women and what that looks like globally. So I'm particularly eager to hear your perspectives on that. And we also, you know, have all of you joining us with perspectives from across a number of sectors, including nonprofit and NGO work, academic work, medical centers and medical sectors of clinical care as well, and across this range of the globe from New York City to Kenya to Nepal. So in terms of thinking about where to start today, I really thought the place that was most exciting to me to start would be with asking each of you to just share a short version of your own story. How it is that each of you, Dr. Basnet, Dr. Naanyu, Dr. Moshirpur, came to be doing the work that you're doing, sort of a summary story of where you started from and the work that you have grown into where we find yourselves today. So I'd really appreciate an introduction for each of your stories. Maybe we'll go in the same order of the introductions, and I'll start with Dr. Basnet, asking you to tell us a little bit about your story of what's brought you here.
Okay. Thank you, Rachel. It's really, you know, I feel it's really, we are connecting ourselves with the global health. And just to start my story, why I am doing what I am doing now, I would like to share one story, my professional journey. As my biodata says that I started as medical officer in very well facilitated hospital in urban areas. I worked for 16 years, but I was not satisfied somehow professionally. Something was, inside my heart saying that you must do something more. So I moved to one of the remotest district in Nepal, where we have no doctors virtually, and the culture is patriarchy society and gender discriminated. Women were considered as secondary citizens. So one fine morning I was walking in the hill, and then I saw one household with crowded people, and family members were crying. So I thought that I must visit what is happening here. I went there, and then I was told that their cow who was pregnant died last night because of during childbirth. And then I said, why you are crying and so much upset? They said, because we consider cow is a very productive economically, because they give milk and they produce bulls for agriculture purpose, and they are expensive. So it's a huge economic loss. Then I understand, I came back. After a few weeks, again, I saw on the other side of the hill, I saw one household with few crowded people, and then I went there. And I found that last night, one pregnant woman who was like 7th or 8th time she was giving birth to a child died because of postpartum hemorrhage. And family members were quiet. They were not, grieving. They were not complaining. And then I asked that your daughter-in-law, she died. It must be a very painful. Family members said, no, this is a normal process. Women, they die. Usually they die during pregnancy or childbirth. It is normal. And economically, not a big loss because we can bring another woman. And they are not very productive because they don't earn money. It's just like household work, we can bring someone else. That is the point when my turning point in professional career. And then I decided that I must work for protecting rights of women, girls, for their reproductive health. That was my, guiding principles. And since that day, now is almost 25 years, I'm working for that. So this is one story I wanted to share. And the other inspiring factor, why, I believe and trust the rural health governance, because in Nepal we had Maoist insurgency, almost like a civil war for 10 years from 1996 to 2000. And that was the period when we were not allowed actively to monitor the service delivery. But amazingly, the 2006 DHS showed that all our indicators improved, including maternal health. Like in Nepal in 1996, in every 2 hours, one woman was dying. In 2006, one woman was dying in every 4 hours. That means almost by 50%. We achieved the maternal mortality, decreasing. And similarly, all indicators. So what I believe that if community takes ownership, if rural health governance improved, then we can bring many changes in the community. So that was my inspiring factor, why I'm more focused on rural health sector compared to urban health, and for the women and for the young girls I'm working.
Wow, thank you so much, Dr. Basnet. Those stories really do capture such a powerful sense of the shift and where your priorities have been as well. Thank you. Dr. Naanyu, could you share with us some part of your story or a story that captures kind of what has brought you to the point where you are today as well? Hope you are muted.
Oh, thank you very much. I have many stories to tell. While she was talking, my senior colleague, I was trying to figure out which one I will tell. First, I was born under a tree. And I keep praying that not too many babies will continue being born at home. This is still going on in my country for all kinds of reasons, including COVID. My path to being a medical sociologist, medical anthropologist was by accident, a good accident. So I encourage people to embrace when the door locks, look out for a window and get out. There's another opportunity. I had a visiting professor come to my university during my undergraduate. So it was just an accident, really, that he happened to come. He came from the US for only that one semester and said, I'm going to be teaching medical sociology. And so our dean and the head of department advertised and said, is anybody interested in this? We have a faculty member just for this semester teaching this particular course. And I just joined the class out of curiosity because I knew if you attended the first lesson, if you didn't like it, you could jump ship and get into the next course. And oh my goodness, his introduction of the course, he described a village near a forest and women going to collect firewood in the forest. And he started describing women going to collect water near the forest. And then how women would be vulnerable to certain conditions that men were not getting. And so he started showing us how you could connect a lot of factors, a lot of variables to understand why women are vulnerable to certain conditions, why they have issues accessing care, affording it, why they have problems managing their own careers and things like that. So I have a lot to tell, but when I finished with that, I realized I was interested in being an anthropologist, in being a social scientist who would understand the background that the patient doesn't bring necessarily to the clinical encounter. That background that affects the plan of management of their treatment and everything that they agree on with the care provider. So I spend a lot of time, as Rachel said, looking at the ethics, looking at the qualitative part, the contextual stories about our patients and why they're vulnerable, why they are unable to access care, and when they get into care, why sometimes they're not adherent. Let me summarize it that way.
Thank you so much, Dr. Naanyu. That is terrific to hear as well. And Dr. Moshirpur, could you just share with us a little bit about your story as well and how you have come here?
Dr. Vernon, let me first thank you for giving me the opportunity to share this podium with 2 or 3 most distinguished women around the world and in New York City. My story is most probably straightforward. When I attended the Shiraz University, which was a university which Shah opened and was affiliated with University of Pennsylvania, we had the old text and professor from the University of Pennsylvania. And when I finished the medical school there, they all encouraged me to continue my training as a resident at Mount Sinai. As you recall, Mount Sinai started the rotating resident from Sinai to Elmhurst. That was the year that the both institutes got affiliated with each other. And it was amazing that the population of the Elmhurst Hospital was very close to the area that I wanted to serve in Iran. Most probably, low socioeconomic and diverse group of population. As you know that we are located in an area that captured the most diverse population in the United States. We translate almost 125 languages a year at Elmhurst. So that was the population that I did love to serve. After I finished the residency, I accept to take a job at the Elmhurst Hospital. And as you summarize my history, I stay here for almost 50 years. What is amazing here for us, especially during this pandemic, how the hospital could serve the population that was the most vulnerable population during this pandemic. As you know, we were epicenter of the disease. And I would mention later on when you give me the opportunity, how did we manage to serve the population? At the same time, I did manage to participate in a lot of societies to just advance the women's health in the community of the Queens and also through the community of New York City. And my best pride of my practice was teaching our students and the residents while I was holding the directorship in the Department of Obstetrics. And I'm so proud to be able to serve this community and also the school.
Thank you so much, Dr. Moshirpur. Actually, let's build on just what you were saying. You know, as we're, I think, all quite aware, you know, in many ways, March has marked for many of us who are part of this group, you know, a time when we really started to understand the global impact of the COVID-19 pandemic when it was officially announced as a pandemic. And as you were mentioning, you know, New York, and particularly the area of Queens, New York, that incredibly diverse area with a population that you serve, where there are quite a number of challenges in terms of socioeconomic status and how the public hospital system seeks to serve that. You were very, very impacted by COVID in those early months. So maybe we could start with you in terms of what it did look like and how your work evolved at that particular time in the pandemic as well.
I was attending a conference at Grenada, St. George University, when I received an email from New York President of Health and Hospital Corporation that the Elmhurst was chosen by the mayor and governor to be a receiving hospital for COVID disease in New York City. And the other hospital was Bellevue. I did not take the message seriously because I did face the Ebola, SARS, and other epidemic in the past. So I thought that this would be another epidemic that we have to face in. But as the month of March started, we were shocked and surprised by the number of the patient and the severity of the COVID-19 problem in our emergency room and hospital. Very soon, we got together as a team. We closed all our clinics. We canceled all elective surgery, and the entire department of the hospital, all surgical subspecialty, from the directors of the service to the resident and attending, were assigned to different areas of the hospital. The hospital was turned to ICUs and a step-down unit. Even we were using our operating room and the anesthesia machine to take care of the patient with COVID. The intensity of the disease was overwhelming. Some of the patients did not make it from the ambulance to even emergency room. We did not have the number of the respirator or ventilator that we needed to really put the patient for their, respiratory problems. On the first 1 or 2 weeks, we were even short of PPEs and other supply that we needed to take care of the patient. Fortunately, through the city health and hospital and the government, we got significant help from Army, Navy, and FEMA. And by the end of March, I had close to 350 providers from different parts of the country, from intensivists to the nurses to the respiratory therapists, to help us out. And what was amazing was the teamwork among the entire staff at Elmhurst Hospital. Everybody came together to do their best. My directors of the surgical specialty were working in ICUs, some of them working even as a clerk and transport. Whatever we needed to take care of the patient at that several weeks, nobody were hesitant to do it. There was no hierarchy among my staff. And that was the best pride of my life, to see that how the team can come together to the best benefit of the patient. The people did not think that they are facing the most dangerous disease of their life. the young people working in emergency room, ICUs, and different parts of the hospital to do their best for their patient. The severity of the disease was overwhelming. The impact, the emotional impact of the disease in our staff was beyond belief. My staff would come to my office, close the door, and would cry because of tension that they had with the severity of the disease. We appointed a team of H3 from the site department and social worker to support our employees, but also several of our staff, mainly from the Department of Pediatrics, arranged a team to cope with the patient. I mean, there was no visitor for our patient in the hospital. They managed to take care of the patient, to be able to see the relatives at home through the iPhone, through the tablet. So at least some of the patients were able to say goodbye to the family. This was the most unbelievable experience of everybody's through the hospital. And for me, it was an experience that I would not forget.
Wow. Thank you so much for sharing that, Dr. Moshirpur. It seems clear that, I guess, in a sense, as the story of COVID at Elmhurst and in Queens is written, it will of course be a very deep and great tragedy. And yet also there is this incredible picture of teamwork, as you describe, and of the ways in which the group really was able to come together and attempt to provide as much support and care as possible in the midst of that terrible tragedy of this infection. I guess shifting a bit globally with our partners here, Dr. Basnett, would you be willing to share with us a bit about how the COVID-19 pandemic has been impacting maternal health in Nepal and your work there?
Thank you, Rachel. As you know, we are least developed country, Nepal. We have limited resources, and that resources we must utilize based on our priority. So what happened after country was WHO announced pandemic? Our government decided to reprioritize the essential health services, including maternal and newborn health services, reproductive and all, sexual and reproductive health services. So what happened? They didn't get priority. COVID patient and their treatment got obviously, priority. So all referral hospital turned up as a COVID hospital. So that impacted on women because they were turned up. If a pregnant woman comes to hospital for obstetric, complications or delivery, women were turned up from hospital because they had to manage, COVID patients. And that affected on women, using their homes for birthing purpose, not attending nearby birthing center also, or not attending hospital because they knew they will turn up. And again, the fear of, transmitting COVID also, that also made them not to attend hospital. So, home delivery, as you know, this is risky, and especially postpartum hemorrhage, because this is one of the major cause in Nepal for having high maternal death. So now UN also reported, and especially 6 countries, that includes Nepal also, with high maternal death, high newborn death, high under 5 children death, and increase the number of unwanted pregnancy because of shortage of supplies, commodities, unwanted pregnancy, unsafe abortion complications. So all these things are, I feel that as if we are going back to 1996, when we had 1 maternal death in every 2 hours. While our, we had achieved so much, like 50% decrease in maternal death. But now every day we hear 3 or 4 maternal deaths somewhere in our country, in the hospital. So this is because of pandemic, but just to share with you, our country just recognized as a federal country, federalism. So political, this is political. So that means country will have three layers, administrative three layers. One central, that is called federal, provincial and local. So every health system was restructuring, like human resources, logistics, supplies, budget, everything was restructuring. And that was happening when pandemic uh, crashed our fragile health system. And now our health system has become really weak to take up the load of this pandemic. So this is really sad, and I feel as a public health, reproductive health, sad that yes, we need to save lives, but also not to forget what we had achieved already, and we were on the right track of reducing maternal mortality in country. But I don't know where, how we will move forward.
I think this is so important what you bring up in terms of putting a light on the ways in which the needs of women and children and maternal health and child health have in so many ways during this last year moved backwards, even as we've of course seen such terrible impact from the pandemic itself in terms of infections and deaths with that. But then at the same time, these other moves backwards. As a pediatrician who works in HIV primarily, we have seen a terrible shift as well, and really worry what we'll see in terms of our ability to prevent new HIV infections for babies that are being born to mothers who are living with HIV, where we know how to prevent those infections. And as we look around the world, our numbers from the UN as well, from UNAIDS, are telling us that women are not able to access these preventive services. We are seeing difficulty in accessing the medicines for those who are living with HIV. And in the similar way, I think we are seeing these movements back to where we had been a number of years ago, and such hard won progress is moving back. So I think it's important to, of course, keep fighting against this, but also to really raise awareness of these ways, especially for women and children where things are being missed and challenges are there. Dr. Naanyu, I know you are a close observer of what is happening around you as a medical sociologist and anthropologist, and in that, seeing what is happening and the impacts, for women, but also, more broadly in Kenya and in the society as well. What can you share with us about how you are seeing the pandemic impacting people living in Kenya, maybe particularly with attention to women or mothers?
Thank you very much, Rachel, and thank you for asking this question. What I did when I got to know about this meeting, I reached out to my colleagues and friends who are doing research in Kenya, so that I would bring to this meeting literally voices from the field. So from what I have I talked to about 18 people. They responded 4 men, I have to say, and 14 women got back to me. And it's very clear that there's been a lot of change in the way research is being done to ensure that ethical practices remain in place. But when you look at women in particular, first of all, it's been difficult to hold meetings, to run focus group discussions, to run group savings, income generating stroke healthcare meetings. It's been difficult to run healthcare worker trainings, mabaraza, the community level types of health education programs. There's been stigma associated with wearing the mask and not having it. So going into the community, some community health workers from the coastal zone and also Western Kenya, they reported to me that people, because others weren't wearing masks, they were feeling stigmatized in different ways. But some of the key things that come out, I'll give an example from a family planning study where the PI said we had a facility-based project that had to be stopped we ran out of funding, and this project had already been implemented to help with family planning, with counseling, and with provision. So we lost that. And a lot of peers working with maternal health around family planning talked about the refills not being available. So we're talking about the chain, the supply, and then also facilities being closed due to COVID. And so even if someone needed to replace their family planning method, whatever they were using, the healthcare worker either wasn't available, or the facility was closed, or there was no good transport to get there. And also there were restrictions on how to travel. And then the curfew, you had to be in a certain place at a certain time. Now, there's a study that was done in 2020 on women and issues around COVID, and it's showing that 60% of the ANC clients and 60% of the postnatal clients reported that COVID had really impacted their decision to seek care, either in terms of frequency or the location they chose to go to. And women reported confusion about how to seek care during curfew, and whether the services would actually be available if they made the effort to travel to get there. Women also talked about being turned away from facilities which had changed their service delivery arrangements. Then maternal child health providers were also facing challenges because not all had received the protective equipment, and some had to work longer shifts. And they are, as you know, Rachel, from your experience here in Kenya, already we have a lot of burnout, because we already had, shorter, fewer workers compared to the client needs and the number of people coming to the facilities. And the other finding from that study was that providers reported concerns about getting infected. And these, a lot of providers, as we know, and where the rubber meets the road, are nurses, and these nurses are female. And so they were worried about going back home, after coming from the facility where a lot of people coming in with the infection were being taken care of, and they were the hands-on people. So this came up a lot. And so also women lost livelihoods with the curfews. A lot of women who peddle or are hawkers, and their customers are in the evening as people come from the office on their way home, they lost that opportunity to bring in some income. And so there were many tables without a meal. And with this also, and with the lockdowns, there was gender-based violence coming up. We saw pregnancies going up, unintended pregnancies, also even for teenagers, because there was a lot of young people, adolescents at home, just lazing around, if I may say it that way, because they were not in school. And so we saw this shooting up, and it was a problem. So I can say, that while COVID has affected a lot of the Kenyan population, including men, it has really hammered the women and the young women.
Thank you so much for bringing both those stories and also the findings from across your colleagues and with people there. I'm struck, we like to try to consider in particular the needs of those who are most vulnerable when we're talking about global health and talking about COVID and in these discussions. And I can already see in some of the stories you're sharing how those who are, as you said, for those who are, they're making their living by selling things, perhaps along the road or the sidewalk, as people are usually being able to walk by on their way home from work, and how the curfew would so disproportionately impact their ability to have any income, and how food security becomes an issue. Any other, specific ways in which you have seen the most vulnerable be particularly impacted by the pandemic? And I know, also in Kenya right now, unfortunately, you are just within another surge of the infection as well, with new restrictions passed this weekend for travel and timing and so on. But perhaps if you could, add a little bit as well about some of the ways in which those who are the most vulnerable in this are being disproportionately impacted as well.
I'm not sure if you mean the most vulnerable to COVID or most vulnerable generally.
I was thinking most vulnerable generally in terms of within the population, although you are welcome to, express that.
So I think with that, from what I have seen, what happened is that because I talked to people who are in care and research programs, when COVID hit, we shifted to using telephone and phone messaging and calling, whether it's doing the follow-up for non-adherence and loss to follow-up, or collecting data like survey data. And so many marginalized people in here, I'm thinking of people who don't have access to a phone, or adolescents who have to rely to use a parent's phone. Actually, there was bias in the sample of people we could follow up and the people that we could actually even engage in our research. So if you were in the rural and very marginalized, so it became sort of an urban and, a bit elitist kind of engagement, because other people, either the connectivity is very weak where they are at, or they don't have access to a phone like the examples I've given, or they don't have access to bundles, like the money to use to buy, to be able to connect. Of course, one of our projects we call it the P4C, the primary healthcare work we've been doing with 4 conditions: cervical cancer, which we know is killing more women than COVID. But this cervical cancer, diabetes, hypertension, and breast cancer, we've been working around those 4 at the primary healthcare level. With that particular group, the vulnerable ones were the aged people living with hypertension and diabetes, and COVID hit, and we had to figure out. I remember Dr. Jemima Kamano, our PI, calling series of meetings, asking, how are we gonna make sure that Mary, who is age X, gets their meds? And if they're coming to the facility, will they get an accompanier? Will they find the healthcare worker? We started thinking of what is called the tackle box. So sending medications in packs in certain ways to the dispensary level and the nearest health facilities to specific villages to ensure that that grandma could actually access this particular, it's a chronic condition, and COVID was there and the curfews had hit. I don't know whether that helps.
Yes, absolutely. Thank you. And I think those are such interesting and important examples of both the challenges that various groups are facing within this, as well as creative strategies to try to overcome some of that as well. Dr. Moshirpur, I wondered if we could turn to you from your perspective. Certainly your health system was very both somewhat overwhelmed, but then really, needed to respond to this incredible need for patients requiring a lot of intensive care and incredible treatment. It's been, of course, a very intense time for the healthcare system. How are there ways that your system has found in approaching the community around the hospital and reaching out to some of the vulnerable populations, or particularly the needs of vulnerable women, perhaps, that you've seen? I know you have such a long history of thinking about how we do screening and how we can better improve primary care and prevention and these connections into the community with this as well. What's been your perspective on this last year for how those needs might be met, or how they've been difficult to meet in the time of COVID as well?
What we did after 2 or 3 weeks of the COVID, we started the screening for the positive COVID test. We had several tents outside of the hospital with the provider that they can do a screening for the population from 7 o'clock in the morning till 8 at night with several providers. We continue providing the care to the pregnant women. We had several pregnant women that they have positive COVID tests. Actually, 2 of them was very sick. One of them, we end up doing emergency cesarean section at 32 weeks, just because she was almost terminal. But it was amazing that after delivery of the baby, she responded to the respirator and she recovered. Baby went home in 7 days, and the mother stayed with us for 4 weeks, and finally went to a extended care facility for a few more days of oxygen treatment. So that was one thing. Now, post-COVID test experience, And with the second attack of COVID, first, I have to say that the second, surge of the COVID, the patients are not that sick. Maybe they come to us earlier. Maybe the treatment that we have for them, and especially mononuclear antibody treatment, is very effective. The mortality is very rare in them. A few terminal one at age 90, 1 or 2, we had mortality during past 2-3 weeks. So we are now very successful. What we are experimenting now that in past 1 year, a lot of patients with underlying medical problem, they were afraid to come to the hospital. And now we get a lot of patients that they are sick because of the cardiac, because of renal, because of pulmonary, uncontrolled blood pressure or diabetes that we are admitting, and our hospital now is full of extended medical problem more than COVID patients. But again, our team learned a lot by COVID actually, and the community. We did continue educate the community by the flyer, by having town hall meetings 2 or 3 times a week for the community, how to prevent themselves from the COVID, the mask, the hand wash, the distance, the general education. And fortunately, with the second surge, our experience is quite different than the first one.
Thank you so much. I'm going to turn to Dr. Basnet yet, but let me just mention again to the audience, we would love to take a few of your questions as well for our speakers. So please feel free to enter questions into the Q&A box that you should be able to see at the bottom of your screen. Dr. Basnet, so returning to you, if you want to elaborate a bit more and for the context of Nepal, how this experience has been for you, for the women around you, and how you've seen those who are most vulnerable be particularly impacted during the pandemic as well.
Thank you, Rachel. As I think in any other developing countries, the most affected are women in the community, young girls, because of, as already we heard from Dr. White from Kenya experiences, because of lockdown, male, our 50, 60 or 70% male men, especially bordering with India, all districts in western side of our country, they work in India because they have to earn money. So they bring money and they bring HIVs also. So because of lockdown, India decided to send all immigrants back to Nepal. So all male, they came back to Nepal, and especially in the rural part of our country, in the very remote side, they don't have job, they don't have work, they don't have money. So obviously unwanted pregnancy number increased, and rape, domestic violence because of no money, pressure, tension. And we read every day there is incidents of suicidal, homicide, or suicide, different ways of different kinds of suicide, and especially mother and children, because mother, she's deciding that cannot really survive. So this is in the community level. And what is happening on the provider side? Nurses, because they are women, and government is somehow restructuring that. Okay, you need to work, you need to transfer, and you need to go some other places. Nurse cannot leave her family, and if she leaves, then like social pressure and cultural values in our like Asian values, that her primary job is to take care of family and children. So the impact is on nurses, and also on community health workers, because community health workers, they are also all women mostly. So their job was to connect community with the referral hospital. And now, because of this stigma, because most of the community people, they started complaining that you are the one bringing this virus, from hospital to our home. So you don't need to come. You don't need to visit our, houses. So that means shortage of supplies, medicine for the chronic patients, and at the same time, women, these community health workers, they are losing their job also. So these are the two sides I see in our country: women, young girls, and then other side, on the provider side, nurses and community health workers. I get every day call from nurses that if I can help them to make it sure that they retain in their same places and not they are being transferred to the other places. So I'm doing my volunteer job. I try to convince the provincial health director or the local level health manager not to transfer nurses. In the meantime, we have this COVID. After this pandemic is over, maybe then it is better to transfer the nurses to the place where really you want, but not now. So some, and again, the gender, inequality in our country. Most of the managers, they are men, and so they don't want to like hear this request. They say that women, if you want job, you have to go, you must go. So this kind of tension, like we are facing here in Nepal.
Sure.
And finally, I wanted to say who are affected disproportionately: disabled people who cannot access health services, and there is no way of transport because of lockdown. So they are also the one, disabled people also, affected disproportionately in Nepal.
Thank you. So I'd like to turn to some of these questions from the audience. And I love this. There's one in our box that came in first that asks, so all four of you, I guess including myself, are distinguished women. What would you say to little girls that want to create an impact in the world, but don't know how to? So what would we say to young girls? Would anyone like to start with their answer to young girls who want to create impact?
I have 5 granddaughters. My advice to them is that I start my residency the time that the female residents were not allowed in surgical specialty, because they did believe that the women are not strong to go through such a difficult residency program. And that was my wish, to become an obstetrician. So I worked hard enough, and even I faced a pyramid residency program at Mount Sinai. From 9 to 4, I managed to be one of the 4. So I tell my granddaughters, if your goal is to reach something, if you work hard, you will get it. It is you, your decision, your determination, and there is no difference between male or female, no matter where you go. It's you that you can, reach your goal. And when I look back in past 50 years at Mount Sinai, now there is almost equality of the job for the female and male.
Thank you, Dr. Moshirpur. I like that very much. Dr. Naanyu?
Thank you. If to the little girls, I will quote one of the female principal investigators who said this to me when I asked her what gives her hope as a female working in a period of COVID. And she said, what gives me hope is seeing so many women who have way less than I have and so much more burden to carry, waking up daily, determined to keep going and change the little space they can. The smile on their faces, despite the pain and fear, what I see in their eyes gives me all the hope I need that we still can and will make it one day at a time. Just to echo that, I just want to say I come from the Maasai pastoral community where girls during my time were not necessarily encouraged to go to school. We were married off as adolescents. And it's education that made the difference. And my parents couldn't even afford it. I got a lot of support from well-wishers to get through my high school. And then I got into college and I got the government scholarship and I was able to finish my first degree, and the rest is history. So for me, I know the key was education. So I would encourage every little girl, just as Dr. Jasmin has said, pursue when doors open, go through them and take every scholarship that comes your way. And when the doors close, I said we use the windows and we keep getting them a lot of education, because without it, they cannot apply for that job with that man who's applying for it. So we don't want to be given free stuff. We want to get it the right way. So I say girl education will lead to empowerment.
Thank you so much. And we'll remember to take the windows as well. I like that a lot. Dr. Basnet, what would you like to say to young girls?
I think, because of time is changing and values are also changing, I would like to advise to our young girls to be capable of handling conflict, risk, and problem solving skills. I would like to by informal training or orientation, I would encourage to be capable of handling the situation, whether unwanted pregnancy, rape, or whatever. Just be like self confident. And there are in the society, in the NGOs and some community based organizations, they are working to create enabling environment for the girls. So of course, formal education is must, but we must make them capable also for handling the problem solving skills. And as early as possible, I want young girls also to to understand that this is their body and they have rights to decide whatever they want. Not by parents should not impose, or even the so-called we are like conscious people. So I want to tell them this is your body, and you have rights to use the way you want and face the consequences and make yourself capable. And of course, no compromise with education.
Sorry, it's muted. These are such great answers. I see we've had a few other questions accumulate about things like how do we help to return girls who have become pregnant back to school, as we are struggling to return youth to school, of course, during and after the pandemic as well. Questions about masks and how we might address the refusals and taboo and stigma around this, and also the questions of as women leaders, what particular challenges and changes in work might you have been picking up as well. I guess sort of recognizing we don't have a lot of time left, I think what I'd like to do is perhaps sort of thinking about some of these questions about where might we be doing research next, or what are some key points within the vulnerable populations that we're serving that have our attention, or new challenges that you've been facing in your leadership positions. I'd like to have a closing word from each of you about something that you're taking as a challenge, but that you want to either try to investigate more or really try to solve, have a better answer for, even as we think about the next 6 months ahead of us. So even if it's a small thing, but kind of what you're thinking about trying to dig into next. Okay, let's Dr. Moshirpur, if you're willing, I'd like to start with you for the challenge for the next 6 months you're taking on.
Well, the issues that you are raising, which did not come to our attention yet, that the number of the unwanted pregnancies in the adolescent is rising. We have a very good support, both from the point of social worker and adolescent medicine people, that they do participate, counseling this young generation. with the birth control and support services. And also, if there are early diagnosis of pregnancy, they guide them with the final decision of that. So I think this is something that it didn't come to our attention yet, but I would make sure that if that is an issue, we have a definite plan for this young generation to participate. Hopefully we don't have too many of them, but in the case, but also the lesson that we learn, I mean, the world is changing and changing very fast, and sometimes beyond our imagination or even thinking that this is going to happen. I think we should be very careful with our young generation. I mean, to guide them in the right track and to advise them with the value of the education. Nothing would replace education for the young generation also. And this is a time that I think as a parent, you have responsibility to make sure that your children are being raised in a right way and right discipline.
Dr. Basnet, what challenge are you digging into or looking at for the next 6 months?
As I said that it was already there, domestic violence was already there, even before COVID, before, pandemic. But because of, pandemic, it like, wildfire, it is spreading so fast. So we know that domestic violence is there, almost there. But we don't know how to deal with them because we don't have evidence-based protocol, evidence-based guideline, or, so anything. So this is where I see a big gap. If we know how to solve this problem, then we can really solve. Otherwise, it's just like talk or domestic violence, everyone is talking about. So fortunately, I'm proud that, I'm also chairing Possible Nepal, this NGO. We have taken this further. We are networking with very, in a place where domestic violence is prevalent among, there are vulnerable community, and women's, all these issues are there. So we are selecting district place and networking with community-based organization, women's group, who are there since long time working on this issue. So we are getting fund from Possible Health for piloting. Through implementation research. So this is why, I like implementation research, because it gives answer, it gives solution, and it really describes a process, how to scale up if we are successful. Yeah. So in 6 months, I'm very much, hopeful that the pilot will begin in networking with community-based women's network. And then we will know who are suffering, why, what we can do. And my vision is then to scale up this model at the national level. Of course, it will be very contextual because all our district is different in nature, but majority of the solution we will know. And for contextualizing, again, it will go district by district. So this is where I am really very hopeful in its next 6 months, we will have a pilot, on domestic violence study.
Thank you. And Dr. Naanyu, what of the many issues you have seen do you want to try to tackle in the next months ahead?
Okay, right now, when it comes to COVID, what has come up, we're rolling out the vaccine right now, and it's in phases, beginning with frontline workers, healthcare workers, the teachers, and now we're going for 55s and 58s and above. And there's hesitancy, even with people who are already frontline supposed to get this. So there's infodemics and misinformation. So I had written a protocol around the risk communication and just trying to understand where people do not have trust in government or do not have trust in the vaccine and issues around that, really social behavioral. And so I hope I can spend a bit of time working on that, because we just began the rollout And we are hoping to see more and more people getting shots in the next 1 week, 2 weeks or so. And then we see how that goes. Yeah.
Great. Thank you. Well, thank you again so much to each of you. I have really, really appreciated this time with you and appreciate that you were willing not only to join us, but, to give us an hour of your evening or your morning, depending on where in the world you are. I think each of you provides such an inspirational example of where we can head. I'm reminded, even thinking about what I would say to little girls as well. There's a children's book I really like called May Among the Stars, which is the story of Mae Jemison, the first Black woman to go into space as an astronaut. And I read this story to my son. And there's a line that Mae's mother tells her over and over again that becomes the theme for the story, which is that if you dream it and you work hard for it, you can do anything. And she's using that to really encourage her daughter to do, just what I think each of you have spoken of, to both dream of the possibilities, to work hard for it through your education and your will and your commitment to the kind of work that you're doing, and then it really makes anything possible. So I thank you for being, examples of that for not only all of us as professionals in this and in the global health work that you're doing, but also, of course, for the children around us and in our lives as well. So thank you so much. Again, this is a monthly series. We will be posting the webinar to our YouTube channel. It's usually up within about 24 hours. So please feel free to share it with anyone who'd like to catch up with this conversation. We'd love to have people join us again next month. And thank you again for your time today. We really appreciate it. Thanks, everyone.
Thank you
very much, Rachel, for opportunity.
Thank you.